any joint difficulties and mobility issues. And this can certainly
Laura,
happen when women have bleeding disorders, just like when men have bleeding disorders. Um,
Laura,
yep.
can I interrupt a minute? I'm sorry.
Yes.
I was supposed to start recording this at the beginning, but I wasn't the host and I wasn't able to.
Okay.
I have now claimed the host position.
Okay.
So I just wanted to let everybody know that I am now recording the session. Sorry about that.
Oops. Okay. um, and so those are some ways that advocacy can be applied in our daily lives. So, but also continuing on, we think about some challenging times in life for women with bleeding disorders. These would include periods or menstruation, childbirth, and the experience of menopause. When someone is diagnosed with a bleeding disorder as a young woman or as a child, how their body will experience sort of each of these milestones is unknown. Not everyone with the same bleeding disorder experiences that bleeding disorder in the same way. And sometimes in families, women will have similar bleeding patterns, but that's not always the case. And even for women who experience heavy bleeding, there can be kind of this sense that that's normal in their family. So that's normal for the person, and not even understand or be aware that the amount of bleeding they're experiencing is outside the expected or normal range, and that there is help to not have such a wearing out effect when you experience that heavy bleeding. Not to mention the cost of all the menstrual products, the cost of clothing that needs to be changed and cleaned, and then some of the social experiences that people have. So, and when you're the person seeking medical care, sometimes families don't talk about these kinds of things in detail. So you may feel like a pioneer, and in many ways you are. So we really want you to know that being able to speak up and speak frankly about these kinds of experiences can be very helpful for yourself and for others. So other common health concerns that arise from having a bleeding disorder include things like dental care. So people will say, when I go for a cleaning, I always bleed. And sometimes they don't get a lot of support from the office. They may say, oh, you need to brush more or floss more. And if you're already doing those things and you're not having cavities, what's going on? So planning ahead and knowing that you need to treat before those dental care visits can help normalize your bleeding profile and make the whole dental care experience more successful. But in any case, if you have to have extractions or any work below the gum, you definitely should be treated. And we at our HTC, we have created a list of dentists kind of in many directions around our HTC who feel comfortable caring for patients with bleeding disorders, or who feel comfortable calling us up if they have questions or concerns. So that's one way that your HTC can work with you in that advocacy role to help educate that dentist or that dental practice, and then have really good care. Then some other areas would include orthopedics, because when people have bleeding disorders, often their joints are affected. And this can lead to joint damage, may also lead to needing surgery or diagnosis of arthritis. And we work very closely with orthopedic teams at our healthcare system, and other HTCs do the same. We also work with community orthopedics providers. General surgery, if you need to have your appendix out, if you broke your arm, if you needed to have your tonsils out. All of these are situations where we can work together with the surgery team, again, to make it a safer experience for you. When women start needing to have mammograms or even breast biopsies, these procedures can trigger some bleeds. So we want to be sure that patients are appropriately protected. A colonoscopy in itself is not a problematic procedure. It's a smooth instrument in a smooth part of the body. That's not the problem. The issue is that if you need a biopsy or a polyp removal, that can lead to bleeding. So you always want to be prepared before the procedure with appropriate coverage. Finally, cancer treatments can occur at any age, but we know that statistically, people are more likely to be diagnosed with cancer as they get along in life. And I will say that because recognizing and responding to the diagnosis of a bleeding disorder in women, as people are sort of the grandmas in the group, are almost like the pioneers for how are we going to address bleeding disorders in women who experience these kind of age-related diagnoses, and what's the best treatment guidelines. And then finally, neurology and cardiac procedures are often considered invasive procedures. And so those will generally require some kind of medical management for the bleeding disorder at the same time to prevent having a complication that's related to the bleeding disorder. Again, our goal is to try and normalize your bleeding profile so that your procedure or your surgery would go ahead as it would for any other person. So it's important. Sometimes people think that their bleeding disorder is only related to kind of like those female things, periods, childbirth, and menopause. But we are all people and our blood goes throughout our whole body. So it's important that that information is shared with your care provider so that the best planning can be made for your safety. So what do you do? Well, education, as always, is the key. We're going right back to basics. It is so important that you get a proper diagnosis for your bleeding disorder. Hemophilia is pretty straightforward in terms of diagnosis, although to be fair, most primary care providers are not experts in hemophilia. Medical school education is limited on bleeding disorders, not to mention women with bleeding disorders. And you may end up being the person to educate your doctor or provider that women do have hemophilia. We were always just considered vessels. We carried our babies and we carried our affected X, which I don't call a bad X, I just call it the affected X. And even the phrase symptomatic carrier implies that you don't have like a valid diagnosis. You just kind of have some symptoms of something. So I could get into the whole patriarchal medical model conversation, but we don't want to do that today. We want to say when you know better, you do better. And so the medical community has finally started to recognize and acknowledge that women have hemophilia and other bleeding disorders. And as I said, any women in this audience, especially the grandmas, are kind of the pioneers of that whole experience. So HTCs can confirm a diagnosis, make sure that a patient receives up-to-date treatment, include a patient in clinical trials if that's appropriate, help develop a plan of care for childbirth or surgery or even daily life. Many HTCs are actually starting formal, separate women and girls clinics because they know that this is an important group that needs special attention. Usually it's a collaboration with an OBGYN team, perhaps, of course, a physical therapist, a hematologist, perhaps primary care, social work, or psychiatry. And then depending on the age of the people that are in the treatment center, they may also include some adolescent specialists, an adolescent pediatrician. And establishing a relationship with an HTC can provide kind of a rest, almost a shoulder to kind of share the burden of living with that bleeding disorder and help you have with that shared goal of your best health living with your bleeding disorder. This can give credibility and validity to your bleeding disorder diagnosis when you talk to other healthcare providers. I'd like to also mention that there's a session today from 3:50 to 4:50 in the main room, and it's titled Care Available via Your HTCs. So that's another way to kind of like, if you're not familiar with the HTC, or you haven't been involved with an HTC before, that you can learn a little bit more about how HTCs work and the services that they provide. But along with the education, we also look for observation, determination, and persistence. Women pay attention. Women notice details. They notice patterns. They make connections. But here's a tip. Write that stuff down. And these days, there's always an app for that. And pictures can tell stories. So pictures of a bruise, pictures of a swollen joint. I'm not being gross here. Pictures of a pad that's got saturated with blood and has clots on it after only 30 minutes. That's extremely objective data that is helpful to a provider who is trying to help work with a patient to manage their bleeding disorder. When you see a medical provider, share your observations and expertise. You don't have to give every chapter and verse on Tuesday at 4:15 p.m. I had this, and then Tuesday at 4:50 p.m. I had that. But you can kind of hit the highlights and have the details available. If you have test results, keep a copy and bring that with you to a visit. Back to education, it's important to know the inheritance pattern of your bleeding disorder. I have a couple of stories about that. We recently had a patient come into our, we are an adult treatment center. So we had this young lady come into our office and she said, my grandfather had hemophilia. So I know that my mom was carrier, but I don't know what my status is. My mom had a lot of bleeding problems. She bruises easily. She had heavy periods. So, but I don't have any of those things. But I'd like to start a family soon, and so I'd like to know what my status is. So we were able to get genetic studies done, and much to her surprise, she learned that she too is a carrier. So her experience with hemophilia was kind of rough because her grandpa lived in the time of infections from contaminated factor and a lot of joint damage. And she was very anxious about the possibility of having a child with hemophilia. But she decided that this was information that she needed to know, and we really applauded her for that. And now she and her partner are going to talk about what they want to do in terms of planning for a family. So that was what we would say a good outcome, where education kind of did the, the goal we had hoped to reach was that the patient became aware of their carrier status. We had another patient come into our clinic recently, and his mom had two brothers with hemophilia. So she thought that she had a chance of being a carrier. She didn't understand that she was for certain a carrier. And, oh no, that's not true. She didn't know what her carrier status was. She had a baby, a little boy, and he was tested at birth. His hemophilia status was negative. So she thought that that meant nobody in her family had hemophilia. She didn't understand the inheritance pattern, and she didn't understand that she had, with every pregnancy, if she was a carrier, 50% chance that the child would be affected. So she didn't have her other children tested. And when her other child had a lot of bleeding, she still didn't have him tested. And it wasn't until his late teens that he ended up in the hospital and found out that he too had hemophilia. And the mom was super surprised. She just didn't understand. So that we're going right back to that. Education is so important. And sure enough, her younger daughter was tested, and she too was found to be a carrier. Because when you're a carrier, every pregnancy has a 50% chance of that child being affected with having that affected X. So, we can't wish away the reality that it's important to have some testing done when we have bleeding disorders in our family. And so I just thought I would do, if this would work in the chat, I'm not sure, Sue, but just kind of like a little quick quiz. So if a woman is a carrier for hemophilia, and she has 4 children, how many of her children will be affected? How many of her children will either have hemophilia or be carriers themselves? Now, I can't see what your answers would be, but Sue can see them. So the question is, if a lady is a carrier and she has 4 children, how many of the children will be affected?
I can see someone typing, so we'll just wait a minute.
Okay.
I haven't received any answers as of yet. Statistics would say 2, but in reality, it could be any or all. Anybody else have an idea? And here again, people in the audience may not have hemophilia and may have another bleeding disorder. So
Sure.
that's, and
Right.
another answer is 1 out of 4.
Okay. So actually, the way that you have to think about this, and of course this is for hemophilia, von Willebrands has a different inheritance pattern, and some of the other bleeding disorders have different inheritance patterns too. So it's kind of going with sort of the easy one. Each pregnancy has a 50-50 chance of being affected. So whether you have 1 child or you have 10 children, it's not half of the kids, it's each pregnancy has a 50-50 chance. So if you had 4 kids, it's possible that 0 of them would be affected, but it's also possible that all 4 of them would be affected. You have to understand, it's like you're starting from scratch each pregnancy. Each pregnancy is 50-50 chance. So if you have 2 affected children, you're not in the clear for the next 2 kids. It's a 50-50 chance each time. So having said that, if you have only 1 child, what are the chances that child will be affected? And again, we're talking about the bleeding disorder called hemophilia.
$50-50.
Perfect.
50%.
Right. And what if you have a daughter and you are a carrier?
It's the same answer.
Right. So that's exactly correct. And remember, bleeding profiles can differ. We have sisters who are both carriers, and one will have heavy periods and one will have kind of pretty light periods. Those same sisters will grow up and have families, and one might have a lot of bleeding when she has a baby, and the other one kind of has very average bleeding. And then as life goes on, those sisters again enter menopause. One has really heavy problematic periods, and the other one might have the normal increase in menstrual bleeding, but nothing unusual. So even though they have the same diagnosis, their bleeding presentation can vary. So that's, that's another part of that story that gets a little tricky. When someone has a less problematic bleeding, do we still cover them? We take their baseline diagnosis seriously. And that's where working with your HTC can make sure that we have the best science available to make sure we have the best treatment for you at all times during life. Okay. So these are some practical suggestions about when you are engaging with a healthcare provider, especially a new relationship, and you want to discuss, you think you have a bleeding disorder, you have a family member with a bleeding disorder and you need a diagnosis, or you know you have a bleeding disorder and you need some type of care. So one of my suggestions is that you ask for the first appointment of the day or an early appointment in the day. This is because bleeding disorders are not super common. And if you come into a provider's office at the end of the day, when they've already had to deal with all of the challenges of their day, and you bring your unusual situation with you, it's going to be a little harder for that provider to give you the time and attention that you absolutely deserve. So if at all possible, try to get them when they're fresh and you're fresh. It's important to be on time because you want to get the full benefit of the visit allocation, the time that's set aside for that visit. You want to have your information with you, and you want to have your 2 priority concerns or questions written down so that you don't get to the end of the visit and say, oh, I really meant to ask about this or that, and we kind of frittered away our time on some of the less urgent concerns. So try to have your priority items written down. You want to take responsibility and accountability. As I said before, when you know better, you do better. You might not have been aware, you might have been reluctant to acknowledge that you had a bleeding disorder. It was kind of dreadful to even think about. So you just sort of try to pretend that it wasn't happening. Don't beat yourself up about that. Going forward, you do the best you can. We do that in all aspects of life. Dress for success. I don't mean you have to come in a suit, but literally when a patient comes and their clothes when they're not tidy and they haven't brushed their teeth and their shoes aren't tied, we know that there's a lot of stress or something going on in their life that prevents them from being able to be really attentive to how their healthcare is going. And we know it's going to be a more challenging situation. So if at all possible, do the very best to present yourself as someone who is really serious about making the most of this interaction. Use advocacy language. Use words like, I would like to be a partner. I would like to collaborate with you in my healthcare. I want to work together. I want to set goals so that it's not a real dependent situation where you aren't involved in your healthcare. Be appreciative of what the provider can offer you, lab tests, treatments, or referrals. You bring a lot to the table. You bring your knowledge, your experience, your family story, and you can work together with the provider and they can get you what you need. As I mentioned, be respectful of the appointment time. And if you don't get the care you need, find another provider. We're very fortunate in sort of our tri-state area that we do have a lot of accessibility to healthcare providers with expertise in these bleeding disorder areas. If people live in remote locations, it can be much more challenging. One upside, and I can't find many, but one upside of COVID experience has been that we have really fast-tracked our ability to do virtual care for patients. And so we have been able to see people who live quite a physical distance away from us. But because of the virtual care, we can make arrangements for blood tests and treatment plans, even in these kind of farther away locations, and coordinate care with other providers in those distant locations. So this is not necessarily as difficult a challenge as it would have been 15 months ago. Having said that, if someone with a bleeding disorder has an injury in a more remote location, those challenges are still quite present. The ability to get to a center that has appropriate medication for someone with a bleeding disorder and staff who are knowledgeable about that bleeding disorder, that can be tricky for sure. I don't have all the magic answers on that one. And I would say to you, this is not manipulation. These suggestions, these are advocacy. This is being smart and using your resources wisely. If you have to bring children to a visit, feed them before you come and bring some snacks for them. Bring diapers and wipes. It's so upsetting for a mom to have a child that has a diaper that needs to be changed and she didn't bring a diaper. And we're in an adult setting. We don't have any diapers, and that becomes a huge distractor. Bring wipes so you can clean that little bum and wipe off hands and faces and places in the room where graham crackers ended up. Bring a book or paper and crayons. You're demonstrating responsibility and accountability, which is what you are. You are responsible, accountable women. And it frees you and the provider up to really focus on your care. This is kind of a place where I thought I might ask if anyone in the group had any examples of times that they advocated for themselves or someone else in their life. Or examples of things that they wish they had kind of done differently and would do differently in the future. in terms of advocacy for themselves or others. It could be related to their bleeding disorder or another healthcare condition.
Hi. Yeah, I've advocated for my kids a lot, and it's only been in the last I don't know, 15 years that I've really started advocating more for myself and my bleeding issues. So all of your suggestions, I think are really good.
Thank you.
I typically have notes that I take with me, and again, like you said, pick, the top couple of concerns that you have. I did have a couple of questions. I know we have access to a lot of healthcare providers here in Michigan.
Mhm.
Do you hear of people having difficulties finding and getting a diagnosis because their insurance limits them to, going to certain physicians?
So that can get quite tricky because almost all health insurances have contracts with certain healthcare providers, whether it's a healthcare system or certain individual providers. We can certainly advocate for an exception for that patient. And in some situations where that just doesn't seem to be workable, and we have some at least preliminary blood work that would indicate that we can likely confirm a bleeding diagnosis, we will, at the place I work, we'll even look at using some of our grant dollars or hemophilia income to help cover the costs of that initial assessment and care, and then give that information back to the healthcare provider that is within the patient's insurance with guidance about how to address that going forward. Sometimes we can have patients, they'll have some opportunities to choose a different insurance provider that allows them to then be seen at our center. And so we kind of will look at the timeline for that. Our social worker is really good at knowing when people's enrollment can be changed. But occasionally we have people that have such strict limits that it almost becomes like, almost like it's charity care is not the right word, but sort of an unreimbursed care that we would provide because we know how important it is that they get that information or that care.
Thank
And
you.
there are very many people around. We haven't met a lot of people that don't have any insurance at all. And in that case, there would be like a payment arrangement made. And again, we would really look at how much they actually needed to pay versus what we could support.
Thank you. I think it's great to know that providers will do that if you're, struggling to find the right physician. So that's good information. My other question specifically for women is, do you recommend a woman who thinks that she may have a bleeding disorder or has a family history of males with bleeding disorders? Do you recommend that they go to get blood work done at a certain time during the month, during their cycle, if they're still having periods?
So we know that estrogen itself helps stimulate or protect factor VIII levels. So for example, in pregnancy, we'll see kind of a bump in factor VIII levels for women who have hemophilia or have low factor VIII levels themselves. We do not see the same bump in factor IX. But so if it's factor VIII deficiency that you're concerned about, we look at testing at a time when the patient's estrogen level is likely to be the lowest to try and get the most accurate reflection of what their number might be. So kind of just after they finish their period would be a good time to draw their levels. Kind of going back to the example of that young lady that came to us whose mom was a carrier and didn't know her own carrier status. She was on oral contraceptives, and we actually had her come off the oral contraceptives for a couple of months so that we would not have that confounding effect of the estrogen from the birth control pills there. that would prevent us from knowing what her actual lab values were. So there is that, definitely that consideration. Did that answer your question?
Yes, and another question was, how does that work with von Willebrand's disease in regards to testing for von Willebrand's disease, because it is the factor VIII molecule?
Right. So again, with von Willebrands, when women are on some kind of estrogen containing product, either for menstrual management or contraception or both, because certainly people will use the estrogen containing products, which would be a birth control pill or the NuvaRing or the patch. They will use them both for menstrual management or birth control. Same thing, if we are trying to make a diagnosis of a von Willebrand's disorder, then we would ask them to come off that estrogen containing product so that we could get the best measurement of their levels. Sometimes people are not willing to do that because they're like, nope, I can tell you right up front, my periods are so god awful that I just can't even bear it. And then we get into a little bit of a personalized dance about what would be the reason for needing to know for sure that they have the von Willebrand's. Do they have upcoming surgery of some kind that would need coverage, et cetera. So it's kind of like you have to sort of have that conversation with the patient and try to look at the risk benefit, the value of the information, what your goals are for knowing that.
Thanks, Laura. Are platelets affected by estrogen? This is another question that came in the chat.
So platelets are fussy little characters. They are in some ways incredibly powerful and in other ways unbelievably fragile. So testing for platelet disorders, especially outside of von Willebrand's, and even some parts of kinds of Willebrands, is notoriously difficult. So we know that there are probably hormonal influences on almost all of the factors in our blood, but we don't have the exact same link to clearly state that estrogen levels affect diagnostic testing for platelets or functional capacity in platelet disorders. So while we might want to, again, try and pull the estrogen containing products out of the equation when we're trying to do testing, that's reasonable. I mean, we take lots of things that we know can affect platelet function to some degree or another: garlic, onions, SSRIs, some other medications. We try to take as many of those out of the picture for at least a couple of weeks before we do the platelet testing. We don't have that same direct X equals Y relationship for the platelets and estrogen for testing. Sorry to have such a sort of a wordy answer that doesn't give you a straight reply.
I don't have any other questions at the moment.
Okay. So this is my last slide. And I just said that bleeding disorders care across the lifespan, from pregnancy to super senior. And for anybody who's over 80 is called a super senior. No, over 100 is super senior. So we expect you to live a good long time. Your HTC and your local chapter have the people and the information to help you live your best life with, not despite, your bleeding disorder. Just a few other comments. If someone is affiliated with one HTC and they're moving, they're going away to university, they're moving for a job or any other reason, your HTC is great. I mean, you could obviously go to the CDC website and search for Hemophilia Treatment Centers, and you can see where they're located across the country. But you can also get in touch with your HTC, and they can help make the connection for you in your new HTC to help smooth the transition when you've got lots of other things going on that are changing with that move. And we've had people that moved to somewhere and for work and were there for X amount of time and then returned to Michigan. And it was just a pretty smooth situation where they could move from one HTC to the next and have no interruption in their care, particularly in their medication deliveries. Because the HTCs, that's one of the things they're really good at, is that coordination of services. And I would like to thank everyone who attended for coming and listening and sharing your experiences and your strength, your knowledge, and also hope that everyone has a feeling of hope that the future is always going to be able to be improved, and we're going to keep working on making things better and better. And once again, women are taking on the challenge of education, support, and advocacy for themselves and their families, because that's what we do.
Any other questions for Laura or for the group for that matter? We have a lot of experienced people in the audience. Excuse my dog barking. The goose chase word for this session is know, and I thought that was a really good word. Know what you need to do to advocate for yourself. And please fill out the evaluation for this session, and you can find that located, thanks Sherry, that is located back on the agenda. If you go back to the agenda, go to the session, there'll be a little box on the right-hand side, I believe, and just click on the evaluation, which is right next to the little blue sign. So thank you for joining us, and please stay tuned. Our next session is at, hold on,
12:15.
12:15.
12:15. I know that because I'm moderating it myself. So I just needed to see.
Thank
which
you, Laura
was-
and Sue.
Oh, thank you. Appreciate it. Do you like my lovely background decoration in the with the HFM butterfly in the corner?
Yes.
That's my top moment in interior decorating.
Thank you, everyone. Have a good day.
Bye-bye.
Bye. I was just checking to see if somebody had put anything else in the chat.
Okay.
There. Nice job.
What do you think, eh?
Yeah, no, I thought it was good.
Oh, thank you.
Like before, people,
Ah, Mhm.
you just never know who's going to talk and who
Right.
isn't. It was good that Sherry was in here. I would
Yeah.
have asked a couple of questions if that was the
thank
case.
you.
But I thought it went well.
Thank you.
You just
I-
don't.
I was trying not to talk too fast.
Well, there was
I-
only one person. There was only one person, and I don't know if she even,
Mhm. Who's
Oh.
Cooper? Do you know who Cooper is?
Oh, no, there were two, weren't there? Yes. No, I don't know either one of the people.
Oh, okay.
I don't know them.
Right.
So
So
anyway, well, very
Okay.
good. Thank you so much for doing this. I really appreciate it. I
Oh.
know that it's trying and you did it. It's just trying. I know that. And I appreciate you taking the time and the opportunity and really highlighting the whole program like you did. I thought that was really great
Oh,
to show that, you know, other people are talking about this issue and believe that it's an important issue.
mhm.
And highlighting that, highlighting HTCs, I think that's really important. And travel and changing HTCs, I think that's also something that's really important.
Okay.
So,
Well, good. I'm glad I hit on those points then.
yeah,
Um,
I am
all
glad.
right.
I thought they were really good points to hit.
Well,
So,
I really appreciate your encouragement and your
not a
help.
problem. Not a problem. Not a problem. So I have to leave to go get to the main stage, but I have to go to the bathroom first. So
Fair. I almost said that. All women need a washroom break.
I should have said it because I was thinking it. So,
All right.
thank you.
All right. I'll
See
talk to you
you.
later.
Okay,
Bye-bye.
bye.